Excellence in Restorative Dentistry lecture series. Welcome everyone. What a great pleasure to have you again, and what a great pleasure it is to have Nassari Mikhailuk with us today. Most of you know him, I'm sure, and some of you may not, because Nas is, I think, in my point of view, and I've seen a lot over the years, one of the true upcoming superstars in the field. I mean, you're already there, I shouldn't say upcoming, but you're still younger compared to most other people who are on the lecturing circuit. And what's amazing about him, you will see. The clinics are, I think, the best, some of the best I have seen so far. And this is why I'm so glad that you're get up at night or still up at night to join us from Ukraine. You have two practices in Kiev and another town, as far as I understand. You have your training center, which is state-of-the-art, unbelievable facility. Thank you so much for being with us. Really look forward to your presentation. Nas, stage is all yours.
Thank you, Marcus. For me, it's a great pleasure and honor to be able to share some of our results, the results of our team. I don't know if many people know, but Marcus is also one of the examples for me, the person that I'm following, the person that I'm learning from, and the person who is inspiring me. So today I would like to speak about the topic that is called analog versus digital dentistry. The topic is really wide. I mean, of course, we have like one hour of a time, and I mean, we cannot cover everything. That's why I picked two specific cases. So one clinical case, we're going to speak about the analog workflow, and another one clinical case, we're going to speak about digital workflow. Of course, there are different cases. There are full mouth reconstructions, there are single units, there are smile upgrades. But today I decided to focus on minimally aesthetic, minimally invasive, restorative cases. Let's say like this. Just before I start with demonstrating the clinical stuff, I would like to introduce myself, just few words for those of you who don't know me. I mean, this is me on the left side of this picture. I'm 4 years old over here, and probably I was not even thinking about going to dentistry those days. I was super lucky in 2004 to travel to US to study for 1 year. It was an exchange program, and it was an amazing experience for me, and also a big chance actually to learn English, because the speaking English you can learn only living among the people who use this language. In 2005, I actually entered medical university. I decided to become a dentist, and I think this picture mostly expresses and shows the level of technology in universities. I mean, it maybe looks a little funny, but that's true. I mean, of course, I never saw things like microscope. I've never seen things like digital dentistry or even top-level analog workflow. That's why when I graduated and I understood that actually I need to upgrade my knowledge. I understood that I need to start reading books, not just going straight to the patient, trying practicing, because when you practice, you need to understand, realize, and being able to analyze your work. And you can only analyze your work when you know how it looks right. If you don't know how it looks right, then it's really tough and difficult to say if your results are good or they are not good. In 2010, I actually became officially a dentist, and I started doing everything. I was doing like a mixed dentistry. It was direct restorations, it was indirect restorations, it was hygiene, so like a general dentist overall. But then I understood that actually if I want to learn doing something well, I need to make a choice to some specific direction. And for me, those days, the most interesting was actually prosthetic dentistry. Why? Because with the prosto, I felt like I could change people's lives in a positive way. I mean, I could improve their smiles. So besides doing it just like work, it was also like a great hobby that I was enjoying and that I'm still enjoying, because without this feeling, the work becomes like something routine. I mean, it's not your hobby otherwise. Plus, in 2010, I started using microscope in my office. At the beginning, it was only for endodontic treatment, because everybody was using microscopes only for endo. But then I felt like I feel really comfortable using microscope. I mean, not only for endo, but also doing direct restorations, also doing prosto. Why? Because there are plenty of benefits. And during the lecture, I'm going to stop at this moment and we're going to speak about this as well. Why I think that working with microscope was one of my most correct decisions in my clinical life. But you know, it doesn't matter which technology you use. It doesn't matter how good you are as a clinician. You cannot be a good clinician if you don't have a good technician. I mean, and I think all of you can agree with that, because it doesn't matter how good you prep, how good you take impression or scan the preparation. If you are not able to have beautiful restoration on top of that, precise restorations on top of that, then the case is not going to be successful. And in my case, my dental technician is actually my father. So yes, it's really interesting and unique experience for us, because we have to balance this communication like doctor and dental technician, as well as son and father. But we manage quite well. And you know, for me, my father is a big person, because you know, he actually was doing in the past metal crowns, then he was doing plastic metal crowns, then he was doing metal ceramics, then he was switching to full contour ceramic restorations, but with the analog workflow. And now, almost 5 years ago, we completely switched to the digital workflow. So what I'm trying to say, that we need always to be ready to change for something new, because dentistry is not standing at one point. New technology is coming, new knowledge is coming. So as we can see, even though we can be good at something right now, it doesn't mean that in 5 years this knowledge will be enough. Mostly sure, in 5 years we will need to have new knowledge for the new technology and new approach. But even having a good dental technician is not enough to complete beautiful cases when we speak about the prosthetic dentistry. It's really important to have a nice team when I speak about ortho, when I speak about surgeries, so doing implants, doing bone grafts. And I have a big pleasure and honor to cooperate with many nice periodontists around the world. I help them, they help me, and together we're trying to manage really interesting cases to give beautiful smiles to our patients. Just a few words. Originally, I'm from Ivano-Frankivsk. It's a small city in the western Ukraine, 200,000 people. And this is where my road started in dentistry. In this clinic that you can see right now on the screen, it's a clinic with the 3 dental chairs. Why I think 3 is a good number? Because this is where you can control the quality. This is important. When you have many dental chairs, it's becoming tough to control the quality. 2 years ago, I decided, and I opened another clinic in Kiev. Kiev is the capital of Ukraine, and Kiev is 15 times bigger city than Ivano-Frankivsk, so the city where I'm coming from. And in Kiev, we fully focused on 2 things. First, 80% of cases that we are doing in Kiev in this new clinic are full mouth reconstructions. So our point is not to have hundreds of people coming to the office and doing 1 filling each. Our point was to start making big cases, big smile upgrades. So the person decides to do the treatment, we do everything as much perfect as possible clinically, and then we just take care of the case. So when we have the proper occlusion in the end of the story, when we have the proper aesthetics, proportion, size, color, and everything treated in the patient's mouth. Another 20% that we are doing in the clinic are actually aesthetic upgrades. That's a combination, orthodontic treatment with 10 veneers case, for example. Nowadays, if we look at the modern dentistry, I think it's a mixture of knowledge. It's not enough just to know how to prep it. It's not enough just to know how to take the impression or make a scan. You need to know many things. You need to know how to create a presentation, how to present your plan to the patient, how to show your previous results to your patient to motivate. Because nowadays, the market is becoming very full. There are many dentists who are motivated, many dentists who are learning online, many dentists who are hungry to grow. And that's why, not to get lost, we need to be always on track and to follow all these things that I'm talking about right now. So is it really digital versus analog? Do they really need to fight these 2 directions? I don't think so. I think it's great be able to combine benefits of the analog workflow with the benefits of digital workflow. I think it's even better if you guys have experience with the analog, because then it's easier to implement them in digital. Is it really progress versus art? This is what we often hear from, for example, dental technicians who are doing the layering of ceramics. You know, my father was doing the layering of ceramics 20 years. So believe me, he is a big fan of feldspathic restoration that we're going to share with you as well in this specific case. But he is now super happy to be able to use digital workflow. Why? We're going to speak about it really, really soon. So let's have a look at our first case, the first case that we did in the analog workflow. Let's see how it works, the step-by-step clinical procedures, and the final outcome. We have this patient in our office with a diastema between the two centrals. And, you know, it's really a funny thing because the patient is orthodontist who didn't want to do ortho. So she actually asked us to help her to close the diastema with a ceramic restorations. Let's have a closer look. What do we see right here? We basically see a minor wear of the incisal edges of the two centrals. We also see a very young patient, and we understand whatever we do today for a patient is not going to last forever. You know, this is the first rule I'm trying to explain to all of my patients. Before they start a treatment, they need to realize that usually after 15, maximum 20 years, they will need to change these restorations to the new ones. That's why already today we need to think about the amount of tooth structure that the patient has in her mouth. That's why we need to improve her smile with the smallest possible sacrifice of the tissue. In analog workflow, we would go with the planning mostly 2D. So basically doing a drawing like DSD from Christian Coachman, you know, I would plan to close the proximal zone, to slightly elongate the incisal edge just to keep a proper proportion of 85%. But again, we have to be really careful with this moment of planning, because some people love having dominant centrals, and some people don't like to have dominant centrals. That's why all of the things need to be negotiated with the patient. It's really, really important. You know, in the past, I was doing most of the stuff thinking that I'm a doctor, I know everything better, and you just have to listen to me and do the way I'm saying it. And now we need to listen to the patients. This is the lesson I learned during the last 10 years. If we want to have a happy patient in the end of the story, we need to combine our knowledge and experience with their dream. Once they come together, then everybody happy, and it's a win-win story for both sides. Then the question is, prep or not to prep? Of course, again, as I said previously, we want to save as much tooth structure as possible. And here we take a decision not to perform any preparation, just to use a double cord technique for impression. So I put a 3-0 cord in the sulcus proximally, and on top of it, I put a 2-0 cord with a viscostate. Why? Because I want the impression material to go as deep as possible in the sulcus, so the dental technician can start squeezing the papilla from the marginal zone. Why? Because we don't want to have a big black triangle after we finish with this patient. That's why I want to start pushing again from as high as possible. Then I take the impression in the analog. I check the impression always with magnification to make sure it's a good quality and send it to the lab. In the lab, the dental technician, first of all, does a wax-up. Now the question is about the wax-up. We all know that all the dental technicians, they have their own signature. So usually a top-level dental technician can design 5 designs of centrals. The average level dental technician can design 3 designs of centrals, and the starting level dental technician can usually make like 1 maybe or 2 designs of centrals. So that means if you guys are working with a top-level dental technician, each 5th case is going to look similar, and this is normal because we're all human beings. It's like us writing on the paper. I mean, we cannot write in 25 different ways. I mean, we have our own signature, and this is how we are being recognized, looking at our signature. Same story with the wax up and with the analog workflow. So sometimes these restorations repeat from patient to a patient because of the signature of a dental technician. This is first limitation of the analog workflow. Besides doing the wax up, he also made a Willie Geller model. And now there is a big question. Which technique should we use to make ceramic restorations in this specific case? Usually when we speak about the analog workflow and ultra thin restorations and the high level restorations, we mean feldspathic restoration. But when we speak about feldspathic restorations, we also have two ways how we can create them. So the way number one is layering on platinum foil, so platinum foil technique, and the way number two is actually layering on the refractory material. And in this specific case, because we need the ultra thin veneers plus as fast as possible, we decided to use the platinum foil technique. You know, this technique is actually super old. It's super old, but it still works amazing in the proper hands of a dental technician. So what happens first in this analog workflow? Dental technician is applying the platinum foil on the dies, adjusts as precise as possible, and then starts layering procedure. So looks like simple case, only 2 units, but not simple for a dental technician. Why? Because he needs to use more transparent ceramics on the facial side to create a transparent look veneer. But when we speak about the proximal zones, he needs to use more opacious material to block the light. We don't want the light to go through too much because otherwise it's going to look gray, the diastema zone. And that's why, again, for dental technician, it's quite a challenge to create beautiful restorations that are going to fix 2 problems on one side and on another side. So which are 3 benefits? First of all, possibility to have ultra thin veneers. The precision of those veneers is 25 microns. Why 25? Because the thickness of the platinum foil technique is about 25 microns. Plus, when they remove the platinum foil from the internal surface of the ceramic restoration, it looks really nice and smooth. So this is what I receive as a clinician from the lab. And now for me is a challenge. How to fix those ultra thin restorations without breaking them. Because you guys, you can easily see it looks like a contact lens in the middle, like 0.1 millimeters. And once you push harder, that's it. Instead of 1 veneer, you can have 5. And then you need to redo it. So the next step, what I do, I go ahead with the isolation. So I use the rubber dam, the heavy rubber dam usually. I use the floss. I invert the rubber dam in the sulcus. In this specific case, I didn't need to use any. So already with the floss can reach the marginal zone. So then when we speak about the non-prep restorations, what's super important? It's super important to know what is a sequence of insertion, because sometimes you can bond the right one and the left one is not going in. Or opposite, you can bond the left one and the right one is not going in. That's why we need to always ask a dental technician, is there some specific sequence of inserting those restorations so we don't get in trouble. Plus, when I'm working with the ultra thin veneers, I always bond them one by one, so not to cause tension so they don't crack. So how it usually looks in the patient's mouth. After sandblasting the surface, because we need to remove a non-prismatic enamel layer, we go ahead and we put the Teflon tape on the lateral incisors. We also prepare with the ACES ceramic restorations, and then really carefully, I prefer to do it with the fingers, yes, I apply and I put in place first ceramic restoration. Then with the brush, I'm trying to remove all the excess material that we can see around. Then we go ahead with the light curing, and when you have a non-prep veneer, it's always important after light curing to go ahead and polish the transitions, the connection zones from the ceramic restoration to the tooth. Why? Because the ceramics cannot be created as a feather edge, just like a metal. If you don't polish the transition with a probe, you will always be able to feel where is the tooth and where it starts the ceramic veneer. And that zone will be a retention zone for the plug and then as the result, inflammation of the soft tissue, staining, and the other problems in the future. After bonding the first veneer, I go ahead and I position another one in the patient's mouth. A really easy push. Sometimes people are asking me how hard you have to push. And I say, sometimes you need to break few to understand how hard you don't need to push. Yes, from this point I can say that, of course, the experience matters. When you tried many of those, you understand that this is the limit, or this is better not to push like this. That's the point. Then we go ahead with a final light curing for the second veneer. And after that, I also go ahead and I polish this transition that you're going to see in a few seconds. All the bonding is under control of microscope. That's why we can see the smallest details. This is a special burr for polishing the composite restoration. Guys, by the way, if you have any questions, you can put them on the side, write down, and I'll be more than happy to answer. After this, I'm using the silicone tips to polish this transition perfectly. And this is maximum magnification under microscope. So what we did, as I said, first, isolation, air drying. Second step, sandblasting. And the third step, etching. After this, bonding and polishing. So here you can see the image, how the transition from the veneer to the tooth looks after final polishing. Day 2, after bonding, looks like this. Of course, we still have a gap. I mean, not the gap, but the black triangle, that's what I meant. But this is what, again, we have to explain to the patient, that after bonding, you will still have a black triangle. Why? Because it takes time for the papilla to go down. We know where is the bone level, and we know that 4 millimeters from the bone level, we will always have the papilla. So again, we need to warn the patient, and then you will not have any problems. Whatever you say after is always an excuse. This is how it works. So the soft tissue under microscope control, we can see it looks nice, no inflammation. Sometimes people are worried to use rubber dam because they say, oh my God, what's going to happen to the soft tissue? Guys, as you can see right here, the soft tissue is completely stable, no problem, nice precision, everything is back and pink. So this is how the patient looked at the beginning of our story. This is how the patient looks in the end of the story with the closed diastema. And this is how the case looks 4 years after. So as you can see, the papilla is 95% down. We don't have any problems. The soft tissue looks nice. The hygiene is nice. Should I do this case to every patient? No, never. Why? Because these cases are very sensitive to the choice of the patient. If the patient doesn't have a perfect hygiene, then I would never do a non-prep veneer to that type of patient. If the patient takes care of the teeth, yes, then I can do in some specific cases non-prep veneers. Why? Because when you have a non-prep veneer, the connection zone between the ceramics and the tooth is always wider. I mean, this small line of composite. That's why. So if the patient is not brushing perfectly, in the future, this line of composite can be stained. That's why be careful with the choice and approach for every single patient. With the analog, everything was beautiful. We were doing small cases like this one. We were doing full mouth reconstructions, prosthetics on implants. You can, of course, have beautiful results with the analog. I know many people around the world who are doing great with analog. But then I started to think about something. I started to understand more and more that what's most valuable in my life, and I understood that most valuable in my life is time. And when I was looking, for example, at my father, and he was working years after years, layering ceramics. We opened one clinic, then we opened another clinic, but he was still layering ceramics. And I understood that we need to change something. You cannot spend 100% of your time just being focused on teeth from morning till evening. Even though I'm a big fan of dentistry, and I'm sure those of you who know me, you know that. But then I thought for myself, okay, I have a goal. My next step is to work less, to produce more, and to enjoy life. And then you can ask me, how come you can work less and produce more? Because these things look completely opposite. And at the beginning, at first, it looks crazy. But actually, now, using modern technology, we can do this. We can give a part of our work that we are doing with our hands to the machines. And machines can help us actually to do this faster and still have free time to do something else. I'll tell you right now that comparing to the analog workflow, our lab nowadays is producing 3 times more cases comparing to the time when we were doing all analog. Now in digital, we can do it easily. Plus, they don't have to work as much. They can work less, but again, to produce more. So, which things are important for us in digital dentistry? First of all, things like scanner. Yes, nowadays, we don't need anymore to put the impression inside of the patient's mouth. This procedure is completely not comfortable. What we can do, we can easily scan the upper teeth, we can easily scan the lower teeth, and then we can show all of this to our patients. So, additionally, it's not only a diagnostic tool, but it's also a tool for communication with the patient. This is the point. And it's a very good marketing tool as well, because people can see right away their problem, and we can, explain everything what we need to do. Another thing that's coming nowadays and the last few years and works for us is actually the 3D printer. So now, no need to pour gypsum models. That takes really time. Now we can design a 3D design of a new smile, or we can design a new working model. We send that information to the software, and then the printer is just printing the model. Nowadays, the modern printers can do it really, really fast without any problems. You can print a model like in 30 minutes maximum. And the model is a very nice quality that can be used to transfer again the mock-up, or you can print a guide, surgical guide. You can print the models for the aligners. Guys, whatever you want, it's unlimited. You can print the copy of iPhone, so no problem for that as well. Besides this, of course, milling machines. So these are now a really important tool that we are using now to mill our final restorations. Mostly, I would say 100%, maybe 99%, let's say like this, of the restoration that we are bonding nowadays, we're bonding monolithic. So basically, the shape is already coming from the milling machine that we can later bond in the patient's mouth. And of course, what's most important besides all of this technology is a team in the lab. I'm sure many of you who are doing digital, you completely understand what I mean, because a person like CAD designer becomes super important. Without a CAD designer, there is no digital dentistry nowadays, because he's the one who is creating all this beauty. So 3 key factors why I love digital. Let's go step by step. The factor number 1 is a new level of communication. Of course, we still do take pictures, we still make videos, always for communication. But now, when we have everything in 3D, it's way easier to explain occlusal problems to the patient, to explain some defects of the teeth, caries, because modern scanners can even scan the teeth, and you can easily show it on the screen. So basically, it's really informative tool to motivate the patient for treatment. Another big benefit of nowadays in digital dentistry is possibility to copy nature. So when we have a young patient coming to the office for hygiene, we see that the patient has beautiful teeth. We say, hey, listen, we offer you this new feature in our office. We can scan your teeth. And if anything happens to your teeth in future, any kind of trauma, maybe wear, maybe something else, you can always come back to our office and we can restore your teeth 100% the same they were when they were fine. Or we can use this library, the natural teeth library, to create ceramic restorations for another patient. So we don't need to create the shape anymore with our hands. We can just copy from nature and give it to the human. And that's why we have this great benefit that we can improve the aesthetics nowadays. And the third one, that we don't have any limits nowadays. So we can do small cases with digital. We can do aesthetic upgrades with digital. We can do full mouth reconstructions with digital. We can do prosthetics with implants with digital. And we have now more than, if I'm not mistaken, like 50 full mouth reconstructions that we already completed with a digital workflow. And all of this, by the way, is documented. So let's go now to the clinical case. So this girl over here came to our office because she was not happy with her smile, with the aesthetics of the smile. You can see she has gummy smile. We can see that there is a passive eruption. The teeth are too much covered with the soft tissue. So now when the patient comes the first time for the first visit, we go ahead, we take pictures, we make videos, and after all of this, the patient comes to the dental chair and we go ahead and we perform a diagnostic scan. How long does it take to make a diagnostic scan? I would say it's like 30 seconds for the maxilla and maybe 30 seconds for the mandibula. I mean, it's really simple, it's really fast, if you know how to use the technology in the proper way. Once again, I want to underline one important thing. Everything always looks easy when you watch someone who knows how to use it. It's like me watching a very good surgeon when he's doing a surgery. For me, the surgery looks so super easy, but it looks super easy because the guy is a professional and he knows what he's doing. So with this technology, it's also important to learn how it works. Where are the weak points? Where are the strong points? And then when you know this information, you can easily apply it in your everyday practice. After doing the scan, we went on with a sounding. I wanted to understand on which level is actually the bone of my patient, to realize, is it just enough to make a gingivectomy or we need to go for the crown lengthening? After doing the scan, we have two ways. We can either cooperate with the lab that is far away, like in my case, now I live in Kiev, I'm sitting right now in Kiev, and the lab that I'm cooperating with, my father, they are in the west of Ukraine. So it's basically 600 kilometers away. But with the digital dentistry, I scan the patient, I push the button, and in 5 minutes, the scan is already on the computer of my CAD designer that is in Ivano-Frankivsk. So super cool with the digital technology. The same story, you can have a mini lab in your office. I'll tell you more. We have both. We cooperate with our big lab that is so far away, but additionally, we have a tiny small lab that has a milling machine and the printer right in our office in Kiev. So something small like printing a model for a mock-up, we can easily do ourselves in the office. So it's up to you which formula works better. You can either cooperate with the big lab or you can do all the stuff in-house. I mean, both ways completely work. So what we got? We got a printed model from the lab, and now we need to transfer a mock-up to have some reference about the zeniths and the new soft tissue position before we do the crown lengthening, because we realize that just gingivectomy in this specific case is not enough. We need first to cut the soft tissue and afterwards to correct the bone level. I was super happy to cooperate with Eric Van Doren in this clinical case. Eric Van Doren is a big dental teacher and a big master around the world. I'm sure many of you know him. And what I did next, I went on with copying the printed model. After I copied the printed model, I carefully corrected the silicone key. I used the bisacrylic material. We inserted the bisacrylic to the patient's mouth. And afterwards, Eric, with a probe, he just made small dots like a reference for himself to cut later on the soft tissue. So the stage number 1 of surgery was actually gingivectomy. After gingivectomy, we went on with a crown lengthening procedure, because if we just do a gingivectomy and we don't correct the bone level, after we put the veneers, we're going to have a violation of biological weight and the full-time inflammation. And we don't want that, that's for sure. And you can see this is how the surgery looked under microscope. So we had to cut quite a lot, let's say like this, of the bone. It was about like 3 millimeters, yes. So you can see now where enamel finishes, and from the enamel, again, 3 millimeters for the new biological width. Suturing in the end of the surgery. So basically, again, this is a very nice comparison. You can see on one side, we have like a mock-up level, and on another side, we can see the soft tissue before surgery. Of course, this mock-up looks bulky, it's not nice because it's going over the soft tissue. And yes, you can see right here, looks even better. You can see how bulky it is over the soft tissue. So we cut the soft tissue, you can see how much, and then this is how it all looked after the healing. So now when the healing is done, we can go ahead to the next step. It's actually the mock-up 3D design. So we are doing another mock-up that now is gonna follow the contours, the new contours of the soft tissue, not going over the soft tissue. So the volume of this mock-up is going to be more correct. Now when we are speaking about the design in the software, a big benefit, as I told you previously, we can use the libraries of natural teeth of those patients who once came to our office to do a hygiene, and we just saw their beautiful shape, and we scan those teeth and we save them so we could use for the other patients. And then we just go ahead, we also can combine this design with a patient smile right away. So this is, I think, a great benefit, because once we design, we can see how it looks with a patient smile on the portrait. So we are not guessing just having the model in articulator. Again, the integration with the photography and with the portrait pictures is just amazing. So then, when the design is done, the design is being printed and the model, again, is sent to the lab. In the lab, once I receive a model, I'm ready to go ahead and start preparation. So many of you can ask, Nazari, why do you need microscope to perform preparation in Prosto? I mean, you can easily do the stuff without any magnification and prep the teeth. Many people around the world do it like this. And I can tell you that when we speak about problems with a dentist, I think you're going to agree with me that many of dentists have problems like back pain, not very ergonomic ways to cooperate with the assistant, and bad visual control. I mean, imagine you see a tooth this size. And I mean, when you see something so small, it's difficult to pay attention to the smallest details. That's why nowadays we have a solution like using a microscope. Why? Because we have healthy position. We have great ergonomics. I mean, we sit straight. We don't have problems with the back. And of course, we have perfect visual control because we have a magnification up to 22 times. Imagine, I mean, the tooth looks just huge. We can see all the minor details, and I truly and sincerely recommend you. Look, without optics, the angle of the neck is 70 degrees, so it's really not comfortable. With binoculars, it's improved, but the most comfortable position is the angle from 0 to 20 degrees. And actually, with the microscope, we can see it completely straight, no problem. What does it help us with? Perfect visual control during the steps like preparation, like over here you can see. Over here, preparation in the sulcus, you can see the bird that has a width only 1 millimeter, but already looks huge. We can also use magnification during retraction because we can see perfectly the positioning of the retraction cord, the control of the soft tissue with the provisional restorations, and of course, the control of the final result after we bond ceramic restorations. I always start preparation with the position number 1 magnification factor, so it's about 8.5 times magnification. And I finish preparation, like finishing the margins with magnification about 22 times. So then we went on with the preparation specifically, and it was interesting because this case was actually a live demo during the Congress in Sofia. There is a Congress called Sofia Dental Meeting, and I was showing this live during this Congress. So we went on step number 1, transferring again a mock-up to the patient's mouth and performing a pre-scan. Transfer a mock-up, wait a few seconds, remove the excess of bisacrylic, then remove the silicone key. Under magnification with the scalpel, we'll remove the excess of bisacrylic. Then we go ahead and we perform a pre-scanning. What is a pre-scanning? My cut designer in the lab always receives not only the final scan of the prepared teeth, but he also receives a scan of a mock-up. So when later on he will be doing the final design, he can be completely sure that the final design matches a mock-up. So the patient is going to get really what we showed to the patient previously, not something different. When I go straight now to the preparation, I usually use 2 kits that I did. One kit is actually for the preparation for full crowns. Another kit is for preparation for the veneers and onlays. After finishing the preparation, if I still have any defects on the surface, I'm using the enamel chisels. Those are hand instruments just to finish the marginal zone to make it really nice and smooth. Additionally, from my cut designer, I received this type of the screenshots. So you can see that on this canine, for example, you can see this blue color sticking from the tooth. So this is the part that I need first to equilibrate on the surface of the tooth before I start transferring mock-up that you saw on the previous video. This is very informative and we can see it really nice over here. So we go ahead. Now the mock-up is in the patient's mouth and our goal is to work as minimally invasive as possible. So I'm using the kit right now for preparation for a ceramic veneers, and I start with the depth cuts. The depth cuts are 0.3 millimeters. Again, my plan is to have very, very thin ceramic restorations. And after this, I'm doing the depth cuts on the incisal edge about 0.7, 0.8 millimeters. Depth cuts are done. I can easily clean all the BIS acrylic from the surface. I don't need it anymore. I have already the reference, these depth cuts on the surface. And then I'm increasing magnification, and I'm very carefully perform this tiny preparation. So as you can see, here it's reduction by maybe 0.3 millimeters, not more. This is why mock-up is so important. We really then control how much we need to reduce. We don't over-prep. This is the point. Both, we don't over-prep and we don't under-prep. So we go ahead. The water cooling is really important, because without water cooling, you can have overheating on the surface and pulpitis in the future. We have this canine that is sticking out distally. That's why I need to prep a little bit more. My goal is to create a micro chamfer all around. The micro chamfer on average like 0.2 millimeters. 0.2 millimeters, this is the chamfer that you can easily visually control when you work with the microscope. Plus, this is the chamfer that will be completely visible for the scanner after finishing. You can see it right now with the magnification about 22 times, a clear, thin line where veneers should be finished marginally. If you ask me about the time, how much time does it take to prep 10 units with the microscope in this microinvasive way? I'll just tell you, specifically this case, I was prepping on stage. I think from the beginning to the end, including scanning, it was about, I would say maximum 2 hours. Maximum 2 hours. So with the centrals, what I need to do, I need to remove the sharp corners, because the milling machines don't like any sharp corners. Wherever is the sharp corner on the tooth, the software will create extra space for the cement. And this will be a weak point during the light curing procedure, because if you have a very thin restoration, but then you have a big amount of cement, and then it light cures, when the cement shrinks, you can have actually a crack, and this can be a problem. Let's move on. After I finished with this microinvasive preparation, now we are ready to go to the next step. And the next step is retraction. When we speak about digital, I can tell you that retraction has to be even way better than when we speak about analog. Why? Because when you guys taking the impression, you push, and then the impression material can go somewhere in the soft. When we speak about digital, you don't push anything. The soft tissue stays where it is. And that's why we need to guarantee a really nice retraction for the soft tissue. Otherwise, the CAD designer will not see it. That's the point. That's why my recommendation, always focus a lot when you are doing the retraction before scanning. And after you finish the scanning, always check the quality of the scan. I prepped the case in Sofia in Bulgaria. I pushed the button and the scan flew straight away to Ivano-Frankivsk, where we have our lab, as you already know. Again, being in Bulgaria was not a problem for me to send all the information to the lab. The power of digital dentistry. What happens next? My CAD designer determines all the margins everywhere he draws. If he is confused somewhere, he can easily make a screenshot and send this information to me on the phone. And I can say, okay, this is correct, or maybe it's not correct. So very simple communication, no problem. He is using completely same library that was used for mock-up. That the patient already saw this design, and the patient is completely relaxed. The patient knows what she's gonna get in the end of the story. Again, matching the portrait picture with the intraoral scan. So basically seeing live how the final outcome is going to look. More pictures we give them, more multimedia we give, more precise and better control of all of the steps they have in the lab. Okay, perfect. Design is done. This is how it looks in the software. Other side, design is being sent to the milling machine, and milling machine is creating these volumes that are not going to be modified. So basically, all the macromorphology we receive from the milling machine. And now there is the last step for the lab. And the last step is the 3D staining. And, 3D staining is a very sensitive moment. A lot depends on the patient and what the patient wants to get in the end of the story. If the patient wants to have a better microtexture, again, the dental technician can add it. If the patient wants to have a maximum natural look, then we go ahead and we perform staining more intense. Some patients don't want to have intense staining. That's why, again, communication is super important when we speak about doing a nice restoration to the patient. I usually ask, how do you see your beautiful smile? How do you see the shape? How do you see the color? How do you see the surface? And then I give some indications for my dental technician how to finish the ceramics and how it's going to look in the patient's mouth in the end of the story. How long does it take to actually 3D stain? It takes about, I would say, for a case like this one, maybe 4 hours. Now imagine, 4 hours for my father to work now, instead of working from the morning till the evening in the past. And now we are coming to the final stage, and the final stage, of course, is bonding. There is no adhesive dentistry in the world that exists without isolation. Well, actually there is. I mean, many people do like this, but if we speak about the right approach, if we speak about the full control, if we speak about the enjoyable process, where we don't worry about the blood, when we don't worry about the saliva, then of course it's better to put rubber dam. To put rubber dam, it will take you 10 minutes. 10 minutes and the teeth are isolated, and we can go ahead with the adhesive workflow using the fluoric acid for about 60 seconds, 9.5%. Then removing all the salts from the surface and using the sealant to improve the adhesion. Once the restorations are ready, we continue with the teeth. We go ahead with etching, 100% enamel, as you can see over here. Then we go ahead with the adhesive system on the surface. Here, I was using already the clamps because we need to push a little lower the soft tissue to make sure that the margins are available and have a full visual control. And then I go ahead with the composite material and I put these restorations in place. Here I was bonding 2 at the same time, so 2, 2, 2, 2. I put restorations in place, I check the precision, then I use the blade after pre-light curing to cut away all the excess of material. Again, it's really comfortable with a microscope because you see where still composite is left and where it's gone. So now let's see. This is how we started at the beginning of the story. This is how we finished in the end of the story with our patient. We were using Empress color B1. Again, the side view before and after. And of course, what I like the most as the person who is using microscope is the analysis of the soft tissue. So here is how the soft tissue looks after healing in the patient's mouth. Emergency profile. Please have a look over here. On purpose, we created a support in the marginal zone so that after the crown lengthening, the soft tissue doesn't go down, but stays on the level where we need. So we created this specific support everywhere on all of the restorations to have control over the zeniths in future. Yes, you can see it even closer on this image over here. And of course, the final step. It's way more focused on the teeth comparing to the picture before. And of course, our beautiful patient after finishing the treatment. Have a look at the smile base. It's completely different, and the final smile of the patient. But what I always like more when comparing to the picture is only a video, because the video shows real emotion and the final results of the patient. Okay. We actually published this case in the journal, in Quintessence Journal in France. So you guys, if somebody speaks French, you are very welcome. You can download it again, Quintessence France, where you can read about all of the details, which instruments we were using, how we were bonding. I mean, all of that. Then a few more news for you. If you are interested to move on in digital dentistry, but you are far, very, very soon we are presenting our new online program that's called Digitalization. So in this program, we will actually have several modules. It's going to be 4 modules where we're going to teach about digital dentistry for small cases, for aesthetic upgrades, for full mouth reconstructions, how to create design on the computer, how to work with the 3D printers, with the scanners. So basically, we're going to teach you from the beginning to the end how digital dentistry works. Those of you who already have knowledge in this and you guys want to improve your skills manually, let's say like this, during a live patient course, we have our study resort, our study center that's called mVision Study Resort. This is where we have all the needed equipment, where we have scanners, microscopes, where I also work with a live patient when I do a case in 4 days from A to Z, from preparation till bonding, right in front of you. And then all of the participants also have a chance, again, to use all of this technology and to bond their own veneers in the end of the story. Everything is shown right in front of the people on the big screen, on the TVs. So 0 details are hidden, and you can see actually the whole workflow, including also the lab steps like 3D staining. Information about me, if you don't follow me yet, you can find either on Instagram or the website. And finalizing my presentation, I would like to tell you one thing. Even though many cases in my life I've done analog and love cooperating with my lab, and we had quite nice results, I think moving digital was one of the most correct decisions in our professional life. Many of you already use digital. Some of you are going to use it very, very soon. It doesn't matter if you're already digital or not yet. I just want to wish you one thing. Always enjoy your work, because when you stay motivated, then you can move on. Once your motivation disappears, again, your work becomes like something routine that you are not enjoying. So stay motivated always, and don't forget to work less, produce more, and enjoy life. Thank you for your...
Great, thank you so much.
Thank you. Okay,
Fantastic.
I'll just add some volume. Yeah.
Oh, great. Thank you so much. And of course, outstanding material, outstanding presentation. So glad all the things you mentioned, because they are really, of course, summarizing the philosophies that we are trying to also, teach to our students. And talking magnification, talking digital, we have huge efforts to make that mainstream for the next generation of dentists. So thank you so much for enforcing that. And the use of the microscope, I mean, yes, I don't know if you're aware of it, but we did some studies, and actually one of our faculty, Margaret Maggio, she actually did a study in our simulation lab where we can track the performance of students with the computer. And we had the class using magnification loops and one class not. And I think it was the only study that I ever saw that scientifically showed that the use of magnification makes you a better dentist. The students learned faster, they needed less help, and they had better preparations in the end of the day. So not only is it just you see more and you feel better about it, it really improves your daily work, and that's so important. I started using the microscope in 98.
I need that study.
I'll send it to you. I sent it to you, of course. And of course, the microscope is the next level. I started using the microscope in '98, but it's still. And by the way, I don't know if you're aware of it, but we had equipped all our endodontics department, and now we're starting to. We have also equipped our prosthodontics clinics, but also now we're really going into our pre-clinics and the pre-doctoral student clinics to also use the microscope on a more regular basis, because I truly believe, and I'm so glad that you're presenting it such a beautiful way to really show the advantage of being able to see. And that is the key here. Of course, some people say, oh, I don't need to see it. Well, when the first time they look at their margins with the microscope, they go like, oh my God.
For those people, I have one important advice. If they don't care so much about the final result, at least they should care about their own health. That's the point. Because, inside of our soul, each one of us is egoistic and has to take care of himself. So one of the big advantages of microscope, which you guys can sit straight and you feel comfortable in the end of the day, not dying because your back is soaring and stuff like this, So that is additional big advantage.
And I mean, I think why it hasn't caught up largely in restorative dentistry is because you have to go to a learning hump. And the biggest mistake I see, I don't know if you agree with this or not. First of all, a lot of times, unfortunately, we're trying new things directly on our patients. Oh, yes, use this microscope on the patient. No, before you do that and before you feel comfortable, you have to practice. Like with everything else, do not practice on your patient. Practice, by yourself in the lab, pull the microscope, practice on the model, and that's how you become comfortable. Because I see so many people using it a few times and then giving up because they don't see the value yet, because it's cumbersome. You cannot become comfortable with it unless you practice. I know what your position is on that.
That's true. That's true.
I have a couple of questions for you, by the way. A few people ask, of course, everybody says, great, amazing, thanks a lot from all over the world. We have people here. Some questions that were first of all, what burrs do you use to polish your veneers? And then how far above the gingiva do you place your finish line? Do you have any guidelines for that?
Okay, what burrs do I use to polish my veneers? I don't polish any veneers. Oh, you mean the burrs in the end of bonding? Okay, I got it. So, thinking about the positioning of the line of preparation. When I speak about the aesthetic zone, if I'm not changing dramatically the color, I always prefer to keep maximum equal gingival. If I'm changing, now there are people who like US style, like for example, bleach 3 color, and I'm changing from A3 to bleach 3. Of course, I'm going to go to the sulcus. How deep I'm going to go deep is, on average, the sulcus of the person is about 1 millimeter. So in that case, we can go 0.5 millimeter in this. So we always have to stay 0.5 away from the epithelium because we don't want to violate a biological width. If you see that the sulcus is deeper than 1 millimeter, then you can go deep to stay away 0.5 from the epithelium. If the sulcus is less than 1 millimeter, then you have to be very careful, and it's better not to go to the sulcus but stay equal gingival, again, not to have the inflammation in the future. When we speak about polishing, I'm using the carbide burrs that are actually for the composite, the one that you saw in the video, and it's really nicely polishing composite. And the thing is, it's not scratching ceramics, because if you use a usual diamond burr, then it's going to scratch ceramics, and then you need to use some tips to polish that zone of ceramics. Otherwise, you're going to have retention of for the plug. By the way, a funny story. One of my patients once went to do a hygiene to another office because our office was closed that day, and I told him, always come to our office. So by mistake, his teeth were cleaned not with the Profiflex, but with a sandblaster. And he had a full mouth reconstruction, Marcus mentioned, and his teeth, all of them were sandblasted. So then 2 days, I was polishing those teeth with the tips for polishing ceramics to somehow improve the case. Just a funny story.
Well, it's pretty painful if you ask me. But I'm glad you see it as funny. Hey, by the way, talking about composites, what are you using for your bonding? You use heated composite or resin cements, or what do you typically use for these type of restorations?
I'm using like it's like a resin cement. I'm using Ivoclar system. Okay, I mean, it's not advertisement. It's just the facts that the last 10 years I'm using this type of material. Why I'm using this type of material, not the heated composite? Because quite often, as you saw in the video, I have a really thin restoration, and actually I need more flowable material to flow, because if I create tension on the surface of the veneer that has a heated composite underneath, I think there is a bigger risk to break that type of restoration. But again, to use the heated composite is also a great option, especially if there are some, imprecisions on the margin, and you have composite that's contacting the outside world. Of course, it's better to have a heated composite that's nicely polished.
What digital system do you recommend, if any? And it's okay. I mean, just tell us what you prefer. Don't worry about advertisement. We just like to hear what you prefer. It's okay.
I put my hand on my heart, and I'm saying the truth. Okay. I'm using the 3Shape system. I'm using both the scanner and the software. If you ask me why, I'll give you one fact. Because it's the whole ecosystem. That's the point. So we don't need to outsource somewhere out of this ecosystem. That's the point. Because it's like, imagine you're a patient and you came to the dental office, and the dentist says, I'm sorry, but I'm doing only veneers. You need to go to another office to do endo over there, but then you need to go to another office to do ortho, and then, it's difficult to control all of the steps. I mean, like in my clinic, what I'm trying to do, I'm trying to bring all the specialists to my patients, and then I'm telling them, look, this is how I see the finish of the treatment, and please help me with ortho, do it like this. Help me with the treatment of the root canals, like this. So the same story with this ecosystem with the 3Shape, because you have possibility to do surgery planning, you have a possibility to do ortho planning, you have a possibility to do all the restorative work.
Interesting question here. How do you match the color for ultra-thin monolithic veneers?
We have, by the way, very nice cases documented on that topic. I'll explain you the case. I did a full mouth reconstruction for one of the patients, I believe, like 8 years ago. And she's a Bruxer. She's from another country, and she never came for the checkup because she lives in another country, and her parents are dentists, by the way. And she cracked 2 centrals that are feldspathic. So when she came, her father came with her because he's always interested to see how it's all going on in digital. And we, just for test, we did 2 restorations feldspathic and 2 restorations monolithic with a staining. So, sorry, I cannot show you because I don't have this information here, but you have to believe me that if I put those side by side, it's very difficult to see the difference. I mean, now if we choose properly the block and we do properly preparation and staining, we can have really nice results. I mean, okay, is it possible for me to share the screen now if I want to show you something?
Yeah. It's up to you. I mean, I don't want to steal much of your time, but it's late where you are, but I'm glad. Whatever, of course.
I mean, no problem. Listen, I had a coffee. I mean, I can talk till tomorrow.
Great.
Okay, let me give me just 1 second. I want to open the case that I just finished. The case that I finished just last week.
That's great.
Just 1 second, just to show you. I'm just going to show you 3 slides. Where is it? 1 second. Going to share. Yeah, sharing options, share screen. Okay, perfect. Okay, let's go. So, here is how we finished the patient after ortho. Do you see the case?
Yep.
Yeah, so this is how we finished the patient after ortho. Then I went on with the bonding, isolation. Then this is the control of precision. It's a dry fit, so there is no cement yet. I just put the restoration in place, and this is how we finished with this. So basically, right here, these are monolithic restorations, just with the 3D staining. This patient, I mean, she said, you can stain whatever you want. So, I mean, from my point of view, I think we can have quite nice result nowadays with the monolithic restorations and staining. And but you know, even in the end of the story, if you guys want to layer, okay, layer. I mean, it's not like, you know, that you have to do only monolithic, never do anything like this, or otherwise we're gonna burn you or something. No, you can actually mill, and if you want, you can additionally stain if you are doing like single central, and you want to make sure it's completely the same like a neighbor tooth. It's cool because you have a choice. You have a choice. I mean, you want to go monolithic, you want to go with the layering. Bigger choices, more choices you have, better it is.
And it's funny because somebody asked exactly that. To use digital workflow for anterior single case. I mean, the great thing is it's not about the tools or the workflow. It's about the patient's needs. And it just, you know, we typically say, well, it depends on what does the other dentition look like. If it's rather, you know, opaque and you don't have a lot of intricate translucencies, you can choose from any material that you want to. Of course, still, if you have a single crown, for example, I mean, if somebody can layer it, you may be able to get more aesthetics in internal when you do internal staining and layering technique. But it depends on the case. I don't think there's one solution for everything.
What I can also add, speaking about digital dentistry, what's important is that in digital dentistry, dentists have to start thinking more. If in analog it was possible just to prep, send the impression, and then make a call and do like this, hey, make something beautiful. Which color? A1.
Exactly.
So in digital dentistry, we need, us as a dentist, we need to understand how these different materials work. We need to understand what is the value. We need to understand that, for example, Emax has a lower value than Empress. So we have to look which tooth we are working with. Is it a high fluorescence of the tooth, or maybe it's low? So we need to make a choice. So my CAD designers, they call me and they say, Nazari, which material we are using? So, and it's my responsibility as a dentist to tell him which one. So then if they give me a veneer and I see that it's like too bright, then it's my problem, because you know, it was my decision. That's why just one thing that I had to learn more is to understand how the optics of all of these materials work. Because now on the market you have different materials. You have Empress, you have Emax, you have different types of zirconia. I can tell you that 5 discs of the same color of zirconia look completely different. I think you know it even better than me because it's your topic. I mean, and what's also really cool, 2 weeks ago, it was very rare, honestly. For me, I was finishing one tooth. It was one molar. And I asked in the lab, I asked them, can you please mill for me 3 different zirconia? So they milled me the same tooth, same anatomy, from 3 different discs. And for them, it was like 0 additional work, almost, like minor staining and stuff like this. But I could put it to the patient mouth and just choose which one fits the best. Yeah. You know, and this is additional answer to the question about the single unit. So with a digital dentistry, you have freedom to make few of them. I'll tell you more. This last guy that I just showed you the case, I made for him at the beginning 2 sets of the trines. We made for him 2 centrals V1 and 2 centrals bleach 3, because he couldn't decide if he wants brighter or no. And I said, listen, you don't need to guess and then think if you made proper guess or wrong guess. Let's make both for you. So we put, you have a look, and then you're 100% confident. And for us, it's not a big investment, but the patient is super happy. He's like, wow, they gave me a choice I could just see in the mirror, and that's it, you know. So these again, these great benefits of digital that I really love.
I mean, I could not agree more with everything you've said, but also that you put people to the test, you know, because what you said about we have to understand the material optics is exactly something people always shy away from, because they want to just, oh, I asked the lab what to use, I asked the lab what cement to use, I asked the lab. No, for us to make the right decisions as dentists, the lab doesn't know this. They don't see it unless you have somebody who comes to your office. And this is, I think, so important that you mentioned it, because it's all about understanding the basics. You don't have to be a ceramic scientist. You just want to understand some fundamentals. And I think this is a duty for everyone who practices dentistry, to understand the fundamentals. Unfortunately, most people just want to have like one material to do everything. Oh, I do everything zircon. Oh, I do everything Emax. I do everything amber. It's not the way to do it. And I'm so glad you mentioned that, because this is absolutely one of the responsibilities that we have. Another thing you mentioned that is very important is that with digital, you sometimes have to be even more recognizing your own work, because yes, you send it to the lab, and once you start doing digital, you understand how much magic sometimes the lab does to identify the margins that you have prepped, and they know that they can do it on the model, and oh, this could be right. Digital, it's not possible. If you don't have if you have not a good impression digitally, you will never find the right margin. It's impossible. And so it's very important that these points that you make here.
You just said about one material. I want to show you one picture, just to smile a little bit. You see my screen?
Yes.
If you use one material, you have this result,
Exactly. Exactly. That's what's happening.
By the way, this is yeah. This is the case.
There's nothing wrong with this. Was this the after or the before?
Yeah.
No, actually, we have. I mean, I'm so glad that you came on board here tonight, and also, of course, our audience here is mostly critical, but also very, very appreciative of you coming and spending this hour and even more with us and explaining how you do things. We look forward to seeing you again. I don't want to say anything because everything's changing on a daily basis right now. Hopefully we come back, visit us next summer. Not fully disclosed yet, but there may be an event. And hopefully can bring you back to university several times. And of course, vice versa, we want to share and then hopefully bring some people to your outstanding center there. So thank you so much. Any final words you have for our attendees?
Well, what I can tell you that, often when we start something new, maybe it's something unexpected for me that you're going to hear now, but, it's even more interesting. Often when we start something new, there are many people around that can say, no, don't do it, it's bad, it's not good, like this. I remember 2010 when I was implementing microscope in my daily workflow, and there were many people who were criticizing this. They were saying, why do you need magnification? Don't you see teeth like this in the mouth and stuff like this? But what happened later on, many people started using magnification, and it's like a normal trend. I don't know about you guys, your countries where you live. Ukraine, the microscope is like a must be in every clinic. It's difficult to find a clinic where there is no microscope nowadays. Personally, we have nowadays 16 microscopes in our study center and stuff like this. So even though somebody can tell you listen, digital is not working yet or stuff like this, people usually say things that don't work yet in their hands. Don't listen to that. Choose your goal. And if you see some problem, choose a bigger goal. My father always says this, choose a bigger goal. And what I did, and I still do in my daily workflow, I was always comparing my work with the very big guys. So I was never looking at the cases in my area or just only in my country, because then when you manage to do something good, then you start thinking that, wow, I'm a hero. But always when you look at big guys like Marcus, their results with his book with Gamborena, and then you're like, oh my God, what am I doing? And then these things really motivate. So as an example, always look at the people who are really top, and then you can grow to the top level as well. And of course, I'm sure all of the people who are watching us today, they will use digital because it's not a future, it's already a present, and we will be happy to help you. So welcome again to Ukraine, to UPenn. We will be there.
Fantastic. Thank you so much. And again, guys, if you are starting with not just digital, most of you are involved, but also with the microscope, just practice. I mean, there's nothing wrong with this at all. Sit down and use it, because otherwise you'll never get comfortable with it. But if you are comfortable with it, you will understand the difference, and you will see the difference. And most importantly, your patients will know the difference. Thank you so much, Nas, for being with us tonight. What an inspiration. What a great inspiration. Your talks always are. It's always a pleasure seeing you. Too bad we cannot be in person right now.
Yes, I think you're doing great work organizing this type of meetings, especially in this time. So, people from around the world can come together and we can communicate like this. This is what we all miss.
Totally agree. And I cannot wait when we come back and do it hands-on again, and we can really learn together. But this was fantastic to get people excited and inspired. I know it's late. Thank you so much for doing this. All the best to Ukraine, to you, and best of luck. Much of continued success. Keep up the great work.